I am Paul Churchard, Chief Geospatial Engineer for HSR.health. Today, I have the pleasure to demo for you the work we have done so far during this 2021 disasters pilot. HSR.health is a geospatial health risk analytics company that provides insights on the relationship between social determinants of health and health outcomes and costs. We have leveraged these insights to produce analytics surrounding the COVID-19 pandemic globally, including in the US and Africa. Our COVID-19 pandemic work was built off of our participation in the previous disaster resilience pilot from 2019, where we provided information on the underlying health posture of disaster-impacted populations. The main theme of this pilot is to bridge the gap between data such as case counts, hospitalizations, flood depth, and weather data, and indicators which provide recommendations for action based on that data, such as identifying areas that are at high risk of being flooded so that residents can be evacuated, or by identifying anticipated patient load so that health facilities can be prepared in terms of staff and resource levels. We find that a useful interpretation of indicators is data that has an associated set of rules, thresholds, or recommendations that can be used to make decisions and drive actions. This is what distinguishes data from indicators. Our aim is to provide levels of recommendation that gives flexibility to emergency response and public health personnel to take into consideration additional on-the-ground data or additional priorities. The purpose of our participation in this pilot is to provide health-related data, indicators, insights, and recipes for the pandemic scenario, and to identify the relationship of the pandemic with the coincident natural disaster, such as flooding or landslide. For this demonstration, I will show our medical supply needs index and how we have applied it for the Rhinemack River Basin in Peru, as shown here, and describe the interaction between the pandemic and a coincident flood scenario. The nation of Peru makes an ideal country for health risk analysis and modeling for many reasons. The effects of climate change on its tropical climate, urbanization, deforestation, and potential for zoonotic spillover events, and the wide range of natural disasters the country experiences, including flooding, wildfires, earthquakes, and volcanism. In addition, there is good access to health and social data down to Admin 3 district level, and PeruStat presents the opportunity for the inclusion of EO data as well. One of the components of the Medical Supply Needs Index is the Pandemic Risk Index, which is comprised of both our mortality and transmission risk indices. The Mortality Risk Index utilizes data on population demographics and the prevalence of comorbidities in order to identify the risk to underlying population of severe illness, hospitalization, or mortality due to the COVID-19 pandemic. The Transmission Risk Index utilizes data on population, case counts, area, and human mobility to identify the spread of COVID-19 by geographic area. The Pandemic Risk Index is a combination of these two indices, which represents both the spread of the pandemic and the health risks that the pandemic poses. The mortality, transmission, and pandemic risk indices are normalized to fall between 0 and 100. Current generalized recommendations from those indices are that 0 to 25 is low risk, 25 to 75 is moderate risk, and 75 to 100 is high risk. The Medical Supply Needs Index produces 3 levels of need: high, low, and index-based levels of need. The high and low levels of medical supply needs are based off of hospitalizations, ICU hospitalizations, supply utilization by type, in this case PPE such as gowns, gloves, and masks, the number of healthcare workers, and the number of first responders like police, firefighters, and EMS. Once the high and low estimates are calculated, the Pandemic Risk Index is incorporated to produce the supply level based upon the spread of the pandemic and the health risk to the underlying population. The recommendation for action to the decision maker will be identified through calculating the difference between the Medical Supply Needs Index and the current supply stock at each hospital and clinic to determine when and how much supply needs to be delivered. With a coincident natural disaster, the medical supply needs calculation can be adjusted upon an increase in volume of patients due to the disaster and based upon a shift in load on the medical system if a hospital or clinic becomes inaccessible due to the natural disaster. As a part of this pilot, we are working with Skymantics, who are building a routing API that can be utilized to move the supplies from distribution centers such as warehouses, airports, or ports to hospitals and clinics. The routing API built by Skymantics provides dynamic routing information that allows for the identification of which roads are passable and impassable in a disaster scenario. We are also currently working with GS1 to utilize their global location numbers to aid in supply chain management and documentation so that decision makers can keep track of where the supplies are going. The Medical Supply Needs Index is housed on our GeoHealth platform, which is our health spatial data infrastructure built on GeoNode and GeoServer infrastructure, which we are expanding with the help of GeoSolutions, another participant in this pilot. This is a geospatial application that can also be implemented on the ArcGIS online infrastructure. One of the regions of interest in the pilot was the Rimac River Basin. The watershed area is shown here in teal, along with the flood extent from a flood on the 15th of March, 2017. We are currently working with RSS Hydro, a fellow participant in this pilot, on obtaining more recent flood extents. Our Medical Supply Needs Index can be overlaid with the Rimac Basin extents and the flood extent with hospital locations to determine the dynamic need of supplies during the flood disaster. As can be shown for this specific flood extent, none of the hospitals are really impacted by the flood. However, we can also add in clinics, which also utilize medical supplies, and we can identify that there's at least one clinic that is within the vicinity of a flooded area and thus might have limited access to medical supplies. Okay. Once these areas of supply needs are identified, we can then overlay supply distribution sites, such as railway stations, airports, and docks, and can utilize the analysis done by Skymantics to get routing information to get the supplies from those distribution sites to hospitals and clinics that need supplies. The data and layers on our GeoHealth platform can be exported or accessed through open standards, including WMS, WFS, GeoPackage, OGC API, and many others. Additionally, a more in-depth look at the underlying data can be found at the analytics component of our spatial data infrastructure. This current dashboard is showing the high level of personal protective equipment need for the country of Peru with a high level of filtering customization, such as dates, districts, as well as any of the metrics we've utilized for our calculation, including social determinants of health and COVID-related data. Additionally, different data points, such as the high, low, and index-based supply needs can be graphed against each other over time for any one district at a time. In this case, we have the red line designating high need, the orange line designating low need, and the blue line designating the risk-based estimate of need for the District of Lima in Peru. Currently, we have produced the Medical Supply Needs Index for Peru and the United States and can replicate it for Canada as well. Additionally, we have created a wide range of COVID-19 analytics for the United States and Africa, partially including the risk of transmission and disease spread and mortality risk due to COVID-19, an analysis of the impacts of social determinants on vaccine hesitancy, the risk of pandemic spread in schools, flights, and offices and throughout the built environment, and performed an analysis of health equity in regards to the COVID-19 pandemic. We have had the pleasure to work with a wide variety of partners so far in this pilot, and we are open to working with everyone participating in the pilot. Thank you very much for your time.